Dr. Ramanuj, good morning.
Good morning, sir. Sir,
Good morning.
am I audible?
Okay. Yes, you're audible.
Good.
I
think
good morning. Yeah, you're audible. Yeah. Good morning. Today we'll have a case discussion on peripheral arterial disease. This case will be presented by Dr. Arjun, who is a second year MS PGT at Balaji Medical College, Chennai, and Professor Ramanuj Mukherjee, Professor of Surgery at Arjigar Medical College, will moderate this session. Dr. Arjun, you can share your screen and present. Wait at the end of history. We'll have some discussion in history points and then pass on to examination and final discussion. Arjun, you can share your screen and start presenting.
Yes, sir. I'll be sharing the screen on Arjun's behalf, sir. I'll just share the screen, sir. Once.
Yes.
Mr. Mehul Patel, if it is okay if I share my screen?
Yes, that's fine. Dr. Arjun, if you want to share the screen, you can go ahead and share. Sure.
Thank you. So good morning, sir. Thank you for the opportunity, sir. Now I am sharing my screen. Sir, shall I continue? Shall we start?
Yeah, start please.
Today I am presenting a case of peripheral vascular disease. I am Dr. Arjun. The 82 years old male from Vellore, who is farmer by occupation, came to the OPD with the chief complaints of pain over right calf muscle for past 1 year, blackish discoloration of right foot fifth toe for past 1 month. History of presenting illness: patient was apparently normal 1 year back. Then he started developing pain over right calf muscle, which was insidious in the onset, gradually progressing, intermittent cramping type of pain, aggravate on walking and relieved by taking rest and hanging the leg down. Initially, patient had pain after walking about 800 meters. He could continue to walk in spite of pain. After about 6 months, he started having pain even after walking about 200 meters and had to take rest to get relief of it. History of trauma by hitting stone while walking over the right foot, fifth toe, 2 months back, following which he developed ulcer associated with pain which was severe in intensity and continuous in nature, non-radiating, aggravate while walking and more during night. Relieved on medication. Patient developed blackish discoloration of right fifth toe since last 1 month. Incidence in onset, gradually progressive in nature. Initially started at the tip of the fifth toe, later progressed to involve the whole toe. There is no similar history over any other limbs. No history of chest pain, breathlessness, exceptional dyspnea. No history of giddiness, fainting spells, blackout, loss of consciousness, blurring of vision. No history of decreased urine output. No history of abdominal pain. No history of gluteal pain. Past history: patient is known case of type 2 DM, systemic hypertension, 2 years, under the regular medication. Not a known case of coronary artery disease, coronary cerebral vascular accident, or chronic kidney disease, bronchial asthma. Patient had undergone extracorporeal shock wave lithotripsy for right renal calculi 20 years back. Personal history: patient is having a mixed diet, disturbed sleep, and a decreased appetite, regular bowel and bladder habits, no history of substance abuse. Drug history: patient on oral hypoglycemic and antihypertensive agents. There is no similar history of similar complaints run among the family. The final summary of my history is: an 82 years old male who is diabetic, hypertensive for past 2 years, non-smoker and non-alcoholic, came with complaints of blackish discoloration of right foot, fifth toe for past 1 month. There is a history of progression of claudication distance and resting pain.
Okay, a good one, doctor. Now, to begin with, you have said that the gentleman was an elderly gentleman.
Yes.
Was a hypertensive, non-smoker, and a diabetic. So, in your summary, it is good that you should include the word diabetes also. And then you have also included that he had a progression of the claudication distance, and definitely now he has a rest pain. Good. Now, to begin with, at this age, or as we have mentioned a few diseases of the arterial system, the first of the questions will be, what do you mean by the word claudication or intermittent claudication?
Claudication pain means it's usually intermittent cramping type of pain which can be reproducible.
Okay, number one. Number
Which I usually relieve by taking rest within few minutes. Sir.
okay. So what is pseudo claudication?
Pseudo claudication.
Pseudo claudication.
The pseudoclaudication also called as a neurogenic claudication. It is a kind of burning type of pain which occur soon after the first few steps, and a patient will be getting relief of it by some postural change. And usually in this case, peripheral pulses will be normal.
Okay, good one. So that means you differentiate a patient of claudication with a pseudo claudication not only by the timing of the pain, but also by the other precipitating factors that produce the pain. Like as you have said, a change in the posture will be about a neurogenic claudication. Okay, so this is number one. Number two, what is a venous claudication?
Venous claudication, the pain will be usually dull aching, continuous type of pain, and patient will be complaining of pain more during the night, sir.
I will be more specific, doctor. Venous
Okay.
claudication will be more in relation to a patient with a deep vein thrombosis in a partial recanalization when there is a venous hypertension. So the better word rather than using a post DVT will be an ambulatory venous hypertension will be the more better word, and as you have said, it is associated with two words that the examiner will want to hear is a edema of the legs, and number two, a bursting type of pain which is seen more at the end of the day because the legs are kept in a dependent way. Next, this is an elderly gentleman.
Yes, sir.
Okay. Now, in elderly gentleman, you have said there is a cramp in the calf region.
Yes, sir.
So, can you think of any musculoskeletal causes in this age that can be producing a similar condition around the calf?
Sir,
Well, see, the gentleman can have an osteoarthritis, number one. Number two is that osteoarthritis with, this is a tough question. Sometimes osteoarthritis is more on one side rather than the other. It should have been bilateral. But osteoarthritis could have been associated with a Baker cyst formation. Now, this is a very rare event that Baker cysts sometimes do rupture, or Baker cysts are associated with a calf type of pain. But when examiner is asking you an unilateral calf pain in an elderly, always remember, always keep an musculoskeletal causes also in this group of the picture. Okay? So this is the first part of the story. Number two, now tell me, doctor, as you have said, intermittent claudication. Okay. Now, what is the origin of the word claudication?
actually, it is a Latin word. Claudo means I limb.
Okay. Was named after a Roman emperor called as the Claudius. Right. Good. So now when we talk about claudication and this, in this gentleman, please take us through the history in which the patient was absolutely normal to begin with, and then talk about the progression of the disease because some of them have joined in late. So please take us through the history in which this claudication occurred.
The patient was apparently normal 1 year back. Then he started developing a pain over right calf muscle, which was insidious in onset, gradually progressing, intermittent type, cramping type of pain, aggravate on walking, relieved by taking rest and hanging the leg down. Initially, patient had pain after walking about 800 meters. He could continue to walk in spite of pain. After about 6 months, he started having a pain even after walking about 200 meters and had to take rest to get relief of it.
Okay, so that means the presently the patient
Yes.
is he in a state of a rest pain? Will you quantify this pain to be a rest pain at the present moment?
Till now, sir, till now from the history, um, I, I don't think so, sir, because it is intermittent in nature. Um,
So, no, say, sir, what is rest pain? Or how do you define as rest pain?
The rest pain is the continuous pain of an calf or a foot or a region, even at a rest, because of an segmental obstruction.
So that is the etiology. Rest pain is technically defined as a persistent burning sensation or a persistent crampy sensation or a burning sensation present for a duration of at least 2 weeks, which requires more than a normal dose of an analgesic, and as you have said, aggravates more on exertion, but is persistent even at rest with dependent posture of the limb. So please remember there are 4 points how you define a patient with a rest pain. So these 4 points, that means more than 2 weeks, requires a more than normal dose of an analgesics, which may partially relieve the pain. Number 3, if the patient walks with a rest pain, the pain will increase, or the patient elevates, the pain will increase. Number 2, the pain is only partly relieved when the leg is kept in a resting state or with a dependent posture. Now, doctor, can you tell me, patients with a rest pain or patients, as you have said, the patient sat on the chair or the bed with the legs which were dangling down. Why does the patient take that posture to relieve the pain?
When patient hanging the legs down, there will be stagnant of blood. Because of that muscle will get extra bit oxygen supply, so he will have a momentary uh, relief of pain.
Arvind, there are 2 points. Number
Yes.
1,
Okay.
dependent posture produces some blood flow by gravity.
Yes. Yes.
Number 2, as then comes your point, that blood is required to stay in that place so that oxygen can be extracted by the tissues. Okay. So whenever you are answering in a postgraduate examination, please remember this is not an undergrad exam. Examiner wants you to have a specific answer for a specific question. So, and definitely we are now here on a short of time. So now this patient did not have rest pain. No? So this patient is in a state where his pain is gradually progressing down from an intermittent claudication distance of 800 meters, and then he now has a pain at even 200 meters. Okay.
Yes.
Now there is a classification called as Boyd's classification for the quantification of the pain. Okay. So what is this Boyd's classification that is used for,
Boyd's
or what is the
classification.
Boyd?
So Boyd's classification give about severity of the claudication pain, sir. Grade 1, after walking for a claudication distance, patient will start develop pain. The pain will disappear after continuation of walking. Grade 2, patient will develop pain after claudication distance. Pain will continue. Patient will continue to walk with an effort. Grade 3, um, uh, After claudication distance, pain will develop, which make the patient or compels the patient to take rest.
Okay, so that means in that one, in out of this 1, 2, 3, and 4. So I'll just recapitalize for or just recap for everyone. One means the patient has an onset of pain, but the patient continued walking. What happened to the pain in one? Did the pain disappear or was the present? Was the
The
pain?
pain will disappear, sir.
Pain will disappear. Very good. What happens in two?
So
The
the
patient is
pain
walking.
will be there, sir. Okay.
The pain is present, but the patient walks with the pain.
Yes.
In three, the pain is present. The patient is compelled to take rest. What happens to the pain?
After taking a rest for a few minutes, the pain he will get relief. Then again he will
Then the patient again continues walking till the claudication
claudication distance.
happens, and then the pain again reappears, compelling the patient to take rest.
Yes, sir.
Okay, type 4 is a rest pain. So please remember that everyone who is listening to this lecture, this is a very important understanding that you must have, that Boyd 2 and Boyd 3
Yes, sir.
needs to be differentiated very clearly in the examination. And examiners has to be and will be asking you the very clear-cut line of distinction between a Boyd 2 and a Boyd 3. Okay.
Okay, sir.
And what is important is Boyd's classification is a very gross idea about the progression of the disease. Now, as definitely we are quickly moving on to, have you heard about other classification systems which also quantify, but I feel Boyd is the easiest one. Have you heard about any other classification systems which are used to quantify that?
So Fontaine's classification, Rutherford classification.
Very good. But well, these are more complicated ones. And what is this Fontaine and this Rutherford classification? That
The
is that we will not be asking Arvind, because you see everyone can get that on their books or internet. But
Yeah.
only for the specific thing is Fontaine and Rutherford both had something called as inclusion of an ulcer or a gangrene as a part of their description. Okay, but we'll come to Boyd because this is what again. So Bailey Love says, and this is what we will follow. So this is all about the classification. That means you are trying to impress upon the examiner that this is an elderly 82-year-old gentleman who is a diabetic, and with time the disease has progressed on unilateral side with a increasing claudication distance. Okay, so this is the point till now. Now, the second point is he also started developing a non-healing ulcer, which he attributed him to a trauma. Now, and this is what has been in the main history. The next slide, Arvind, you have told about he had complained of other problems in other sites. Like you have mentioned about chest pain, dyspnea, etc. Why did you mention about the history of chest pain, fainting spells, etc.?
Sir, to rule out any other system have been involved. Yeah.
Okay, so it is better called other systems, as you have said. Like, sir, I wanted to rule out a myocardial ischemia, and then you have told about abdominal pain and decreased urine output. Now, decreased urine output is not a very specific point.
Okay.
Remember that it should be more better quantified that he did not have a history of bilateral pedal edema or swelling of both the legs, facial edema, or a decreased urine output, suggesting a kidney compromise. You have said about abdominal pain. What is the type of abdominal pain that you want to impress?
The patient will be telling a postprandial abdominal pain, sir.
Okay. Which part of the abdomen? And what is the vessel that you are thinking that will be blocked?
Sir, it is mostly a mesenteric ischemia.
Which artery? It is usually the superior mesenteric artery followed by iliac, which will be parallelly blocked. Remember, the superior mesenteric artery has the largest caliber, and it is usually the atherosclerotic occlusion that is going to occur at the mouth of the artery. So the patient is going to present with a postprandial, epigastric, or upper abdominal pain, which will make the patient with a triad of a loss of body weight, postprandial pain, and a fear of food. So this classical triad is a patient of a chronic mesenteric ischemia. You have also told about gluteal pain. Why did you impress upon the gluteal pain?
If there is a iliofemoral block, the patient will be having a gluteal pain of like thigh pain.
Okay, that's good. So that means now you are talking about that, sir. I wanted to specify which part of the vessel is blocked. Very nice. Now, doctor, if there is a aortoiliac claudication or aortoiliac obstruction, very sorry,
Okay.
what are the characteristics area that the patient will present with pain?
Then again a gluteal region and thigh.
Okay, now see, Arvind, this is an undergrad question. Remember that if the aortoiliac region is blocked, it is usually a downstream event. So that means you will have a claudication in buttock, thigh, and the calf.
And calf.
Similarly, when you have an iliac obstruction, where will you get the pain?
Sir,
If the common iliacs are blocked, again, it is an unilateral claudication of thigh and the calf. So please remember,
okay, sir.
initially we said the buttock, which was both. It could have been both the thighs and both the calf. In an unilateral iliac, you have unilateral claudication of the thigh and the calf.
Okay,
In a
sir.
femoropopliteal obstruction, we are going down now.
Okay.
Where is the pain felt?
Sir, calf muscle.
Again, what is the word that I used? Unilateral.
Unilateral.
Unilateral claudication in the calf. Very good. If there is a popliteal or a distal obstruction, where is the pain felt?
Calf muscle
And the foot.
foot. Yes.
And the foot. So these are things that the examiner will ask you. Good one. Now, Arvind, come to the next slide on what are the etiologies that or the histories that you have taken. So you have taken a history about diabetes, hypertension. Was the patient a smoker?
Sir, no, sir. He has
Oh,
no history of substance abuse.
right. So he did not have any history of smoking. Good. Now, in this aspect, Arvind, it is very you are a very good student. So it is now an appropriate time to ask about that. Let us talk about the factors very quickly. Now, when you talk about age as a factor for a peripheral vascular disease, what are the nature of the vessels or what is the type of the anatomy that is involved by age-related peripheral vascular disease? That means, are proximal vessels more involved or are distal vessels more involved?
Distal vessels are more.
Age-related narrowing. Did you get my question?
Yeah, sir. Yeah.
Okay. So what happens when there is an age-related narrowing? We need to be quick, Arvind. We'll move on to the
It
exam.
will be generalization and
No. With
more.
age, please remember,
Okay.
the obstruction is more seen in the distal limbs. That means the caudal arteries, followed less in the femoropopliteal, followed minimal in the iliac. So you expected otherwise. No, it is not. Age, remember, produces a block distally, then femoropopliteal less, minimal in the upper part. Now, when you talk about hypertension, because remember this elderly gentleman was hypertensive, what is the nature of involvement of blood vessels? Proximal, mid, or distal?
Distal.
So remember, hypertension affects all vessels, large, medium, or small. That means iliac, femoropopliteal, and caudal equally. What is the nature of involvement in diabetes? What happens in diabetes?
The diabetes will be the endovascular.
Again, in diabetes, the more you go down the leg, involvement is more. That means crural is more, femoropopliteal less, and the least will be ilia. Finally, what happens in smoking? In smoking, remember, the more you come from above, that means iliac is the maximum, followed by femoropopliteal, followed by the crural. Remember, we are talking of atherosclerotic disease. We are
Yes.
not talking of Berger's disease.
Yes.
So I will just have a quick summary about what is important for you to remember. It is good that you should have this look from Sabiston, because Sabiston mentions this very brilliantly, that what is the relationship of atherosclerosis in the various factors. Remember, we are not talking Berger's. Berger's is a different category. So these are the role of the various etiologies in this patient. If the patient is a smoker, then the examiner would have quantified about the pack year index and what is the relationship of the pack year index in this patient. So this patient is not a smoker but a diabetic and this. Now tell me, doctor, what is the reason of atherosclerosis in diabetics or hypertensives? Or how does atherosclerosis develop in diabetics and hypertensives?
Sir, in diabetic patients are diabetics are one of the risk factor for atherosclerosis.
Yes.
And then
How?
sir, in diabetic patients that endovascular usually get injured, uh, and that will be sealed by following a platelet aggregation later on.
So definitely, yes. Again, see, there are a few words the examiner wants to hear. You have said the word. The atherosclerosis is a degenerative, chronic degenerative inflammatory process. What is important is hypertension produces an endothelial injury, which initiates the plaque formation. Diabetes is associated with more glucose levels in the tissues, which leads to an inflammatory response and aggravation of the plaque. So these are the things that you should know. I think, sir, with this, we can go on. He has had a very good
Yes,
answer.
yes. We have good discussion. One question, Arjun. You
Yes,
said
sir.
in grade 1 claudication, the pain disappears.
Yes, sir.
So in spite of ischemia, how does the pain disappears in grade 1 claudication?
The pain disappears because of the collateral blood supply, sir.
Yeah. So this patient has got mild ischemia. As the patient walks, the collateral opens up, and
Yes.
that washes up the pain-producing substance. That is the explanation. Yes,
Yes.
good. Yes, otherwise you have answered well.
Yes.
Okay, so he must be knowing the explanation. And this patient who has got a gangrene, he said black black discoloration. Once you have black discoloration, that is the end point of severe ischemia. Patient has got severe ischemia will have black discoloration, and the pain you describe for this black area is equivalent to rest pain. You see, patient has got a gangrene and he has got pain in the local side in the foot, and that pain is continuous for day and night. He is comfortable at night, hanging the leg below the bed. That equals rest pain. Dr. Ramanuj, what do you feel? If
Yes,
the patient has
absolutely.
got a,
Because,
if the,
sir, because after you are told about the examination, Arjun, or in this aspect, you are appropriate in a position to answer. What is a CLTI or a chronic limb threatening ischemia? How do you define a CLTI? Arjun, what is a CLTI? Chronic limb threatening ischemia.
see, it is marked by what? Patient has got severe ischemia, so patient will
It's
have a
a
rest pain.
chronic, sir. Chronic limb ischemia is defined by
No, Arjun, my
No,
question is very
limb threatening. Limb threatening.
chronic
Limb threatening
limb
means
threatening ischemia. Please mark the word
okay.
CLTI. Arjun, the answer is patients with ischemic rest pain with or without ulceration gangrene tissue loss are called to have a chronic limb threatening ischemia. I will again repeat. Ischemic rest pain with or without ulceration or gangrene are termed as a chronic limb threatening ischemia. That means this patient technically has, as we have said, gangrene is a chronic limb threatening ischemia. So this is the last. That means if you have talked about that Fontaine, Lerich or the Rutherford, these are the last of the categories. Okay. So this
Okay,
patient is in something called as, we now call this term CLTI. Initially, we have to have a term called critical limb ischemia. This term is not used anymore. We now have a term CLTI. Okay. Please move on to the examination.
Yeah. Examination, please.
Please.
General physical examination. Patient is conscious, oriented, and cooperative. He is moderately built and nourished. Height of 160 centimeter, weight 62 kg, BMI to 24.2. No pallor, ictus, clubbing, cyanosis, generalized lymphadenopathy or pedal edema, and temperature is afebrile. Pulse rate is measured in the right radial artery, 90 beats per minute, with regular rhythm, normal volume and character, with no vessel wall thickness, and there is no radiofemoral or radioradial delay. A blood pressure of 130 by 90 millimeter of mercury measured over the right arm. On local examination of lower limb, inspection of the right lower limb. The patient was examined in adequate light and exposed after obtaining a consent. Attitude of the patient is normal. Dry gangrene of a fifth toe of a right foot, black in color, shriveled, seen with a clear line of demarcation at the level of middle phalanx, proximal area with no signs of inflammations, and the proximal joints, range of movement is full and free. The skin was thin, shiny, with loss of subcutaneous fat, loss of hair over the foot and lower one third of the leg. I can see a brittle nail with a transverse ridge. On leg elevation, there's a guttering of vein, no muscle wasting or no dilated or distended veins seen. On examining the left lower limb, it is also having a thin, shiny skin with loss of subcutaneous fat and hair over the foot and the lower one third of the leg. Toenail appears brittle with the transverse ridge. No evidence of any ulcer or gangrene in the lower limb, left lower limb. On palpation of the right lower limb, the temperature is gradually gradient and periphery is cold. Tenderness present at the junction of normal skin and gangrenous area in the right foot. Proximal area of the gangrene, mild edema present. The muscle, on measuring the muscle wasting, right calf 21 centimeter, at the left side it was 23 centimeter. In the thigh it was 41 centimeter, in the left 44 centimeter. In first there is some muscle wasting present. On palpation of gangrene, it is hard, shriveled, no sensation, no cryptus. Capillary refilling time is delayed. The Harvey's test is more than a second, and the ABPA is 0.4. So there is no evidence of superficial thrombophlebitis. The joints, the range of movement is full and free. No inguinal lymphadenopathy present. Sir. On palpation, the left lower limb, gradual temperature gradient and the periphery is cold. No temperature present. No tenderness are present. No evidence of superficial thrombophlebitis and no inguinal lymphadenopathy present. Sensory systems are normal according to the age. Tone, power, reflex are elicited. Peripheral pulses, dorsalis pedis and anterior artery are absent in the right lower limb. The left, it is a feeble. Posterior tibial artery, popliteal arteries are feeble in both right and left lower limb. Femoral, radial, brachial, axillary, subclavian, and superficial temporal artery, common carotid arteries are normally filled. On auscultation, there is no root third over the femoral and carotid. Other systemic examinations are normal. My summary is 82 years old male, a known case of type 2 DM, systemic hypertension with no history of smoking and alcohol, with complaints of pain in the right leg for 1 year, blackish discoloration of the right foot fifth toe for 1 month. On examination, dry gangrene of a right fifth toe with signs of ischemia, with absent pulsation over the right dorsalis pedis and anterotibial artery, suggestive of peripheral artery occlusive disease affecting the right foot fifth toe, probably due to atherosclerosis, sir.
Okay, good one. Now, when you come back to that examination, Arvind, it is good that you have told about everything. Now, in the general, it is called general survey. It is not technically general physical examination. Okay. So, you have told about the BMI, you have told about the febrile and these points. I think you are good into this about this aspect. Talk to the now the local examination. Now come to the next slide. Now you have said local examination of the lower limb. Yes, this is also good. You can also say this is examination of the vascular system of the lower limb. The exposure of the patient in a vascular examination, remember, always starts from the abdomen because there could be scars about aortic surgery or lumbar sympathectomy which will have been missed out if you have not seen the abdomen. Okay, so whenever you are trying to show a patient or see a patient, always try to examine from the abdomen down. Remember, the aorta comes from the abdomen to the legs. Okay, so this is the way we go about this. Always describe the normal limb, then go to the abnormal limb. That means in this case, the left was normal, the right was abnormal. So this is what is the first thing to be said. The rest of the things you have said to be normal, and you have said attitude is normal. You should also say the gait, G-A-I-T. Gait means the way the patient is walking. Like in this patient, probably the patient has a painful or a limp while he is walking. Does he use any stick? Arvind, does he use any
Pardon,
stick?
sir?
Does he use any device to help him in walking?
No, sir. No, sir.
No, good one. Right. So I think that you are good enough on this aspect. And can you go to the next slide? Okay, what is the temperature of the limb in relation with the other limb?
Sir, periphery, it was cold, sir. In both, it was. I can feel a more cold over the right, but still I will comment. Like left side is also cold, but gradually when I ascend up,
In bilateral disease, how do you compare? Comparing the lower limb or comparing the other part of the body?
sir, other part like thigh also can take into
Not thigh.
consideration.
You see, the lower limb is disease, you comparing the upper limb.
Okay.
So this is a very important question that you should have. Now, tell me, in a patient with an acute limb ischemia versus a chronic limb ischemia, what are the signs in an chronic limb ischemia that are, or what are the signs of an acute limb ischemia that are not present in a chronic limb ischemia?
Sir, usually the duration will be lesser in acute limb ischemia.
Okay, Arvind, do you remember acute limb ischemia goes by those 5 P's, na? Sudden those pain, paresthesia, etc. Remember that in a chronic limb ischemia, there is no paralysis. And as we have said, the sensation over the limb, remember, except for that gangrene area, is still preserved. So that is the difference between an acute versus a chronic. Both of them will have a temperature difference, and the pulses may be lost in both. Okay, so this is a small subtle difference. Now, in this picture, as you can say, there are some subtle signs of a chronic limb ischemia, as you have very rightly mentioned. Skin changes, so you can also club them like changes in the skin, changes in the nails, changes in the subcutaneous tissues like loss of fat. So these are all. It is also good to see about other ulcers. Can you tell me what are the areas in the foot and the leg which are more predisposed to ulcers in this group of patients?
Then the heel,
The
and
most
then
common will be the dorsum of the foot, followed by the lateral aspect of the foot, then followed by the heel, then followed by the tibial region. Okay, we'll repeat: dorsum, lateral aspect of the foot, the heel, and the anterior aspect of the tibial region. So these are the four classical sites. Examiners will not usually be asking about what happens in a venous disease and a neurogenic ulcers or a neuropathic ulcers in this way. So this completes your ulcer stories. And if there is an ulcer, the examiner will try to describe this ulcer. Why did you say this is a dry gangrene?
On the examination, it is dry and shriveled. There is no cryptus, and there is no edema. There is
Number one, there is a line of demarcation. This is
yes,
the what examiner wants to hear from you. There is a line of demarcation. How do you define the line of demarcation?
So
Or
it
what
is
is
a line. It
demarcation?
is a line between the viable tissue and the dead tissue. Usually, at this level, there will be hyperesis.
Okay, so it is a line of granulation tissue. So the examiner wants to hear part of the definition, which differentiates an area of an dead limb versus an area of perfusion. Please do not say it is normal area, because the line of demarcation can be in an area of an ischemia. Okay. Now, in the limb that is adjacent, that is the fourth digit. Okay. What are the changes in ischemia that are very well evident that suggest it is a chronic ischemia?
So, pardon, sir.
See the fourth digit, the picture that is shown by the side of the gangrene. What are the changes that are going to tell you that yes, it is a ischemia? Or in another word, how do you define a pre-gangrene?
So pre-gangrene is changes in the tissue that is like inadequate blood supply to keep the tissue alive. The patient will be having a wrist pain, or there is a color changes seen here, and then edema.
Requested before. Arvind, please be specific to one question. Pre-gangrene is defined as a state of impending tissue loss, number one. Number two, marked by purplish or a congested appearance of the limb, but the temperature is retained as normal with a sensation as a painful area of the limb. So that means the examiner wants to hear impending gangrene, purplish discoloration, loss of pulses, but pain is present and the temperature is still present. So that is called as a pre-gangrene. So there are 5 points to know in a case of a pre-gangrene. Good. So you have mentioned it more or less, everyone. You have mentioned the pulses in the limb. You have also mentioned. Did you auscultate the blood vessel?
Yes, sir.
Okay. Why did you auscult?
Sir, to check for a bruit.
Okay, to check for the bruit. If there was a bruit, what would have been the disease that would you have thought for?
Sir, that's telling me there's a narrowing of the lumen.
Okay. The
And,
presence of a bruit would have meant, as we have said, there are two diseases which will present with a bruit.
okay.
One is a critical stenosis. Number two is an aneurysm in the peripheral blood vessel. In this region, when you palpated the region of the popliteal artery, did you feel any presence of any pulsatile lump or a popliteal artery aneurysm?
No, sir.
Okay. Which is the most common peripheral artery aneurysm after the abdominal aorta?
Sir,
In this,
pulmonary.
please remember that this is the typical age group of a patient with a popliteal artery aneurysm. And popliteal artery aneurysms, always remember, are bilateral in 50% of the cases, are diagnosed in men over 7th decade. That means this is your typical patient of a popliteal artery aneurysm. And always remember that popliteal artery aneurysms can be a cause of an embolus to the limb. So this is a small point. We will not digress from the topic. So these are all the special things that you are required to know. Okay. So now come to the exam.
Person to management. Person to management.
Management part.
Right. Let us go
Person
now
to management.
to the management. You have mentioned it very well, Arvind. You have gone absolutely on all the nitty-gritties for a postgraduate exam. Okay, I've also mentioned the ABPI, which is a very, very important thing, and you should have, if everyone should applaud you for that. What is the ABPI in the opposite
No,
case?
but Ramanu, should say ABPI in exam because it is sometimes difficult to measure the ankle blood pressure using a standard cuff.
Sir,
So I think
right.
ABPI we can skip.
Sir, yes, sir, this is the reason. If ABPI, if the cuff is given to you, if you have a handled Doppler, I think, sir, there are various examination centers who now insist that ABPI should be given as a part of even their DNB. So if you have measured,
Yes, if you have the cuff, if you have to have the cuff, you have a Doppler
yes,
probe to listen to the sound, then only you can say. But otherwise, if you are
then
given your only standard
definitely,
stethoscope,
exactly, sir.
you wait. This can
You
be
can,
discussed while going for investigation. But stato is a ABPI, and you say I've got only standard stethoscope and the normal BP cuff.
You cannot measure ABPI with a standard stethoscope. You will always need a handheld Doppler for that. Right. Arvind, so now let us go to, so what is your plan in treatment of this patient now?
Sir, I will be advising the patient to control diabetes and systemic hypertension, and he is a bit obese. I have to check for his lipid profile, and I want
You
to correct by
first try to confirm the diagnosis. Is he diabetic? How is the diabetes? Whether he has got any lipid abnormalities, whether he has got the ischemia involving which vessels. These are the things first to be settled, then going for specific treatment.
Okay, sir.
So you need some investigation to assess the patient. What?
Okay.
How do you start?
Sir, I'll be asking for a CBC, RFT, and then
How CBC is going to
profile.
help? Why you utter CBC first? If my question is, what the relevant investigation, how is the CBC is going to help in this patient?
Sir, it will show me like infection by leukocytosis, and then there is any like he's undergoing
As a
any
gangrene, you can have
anemia.
a point that whether it's got leukocytosis. Apart from this, you talk of more important points. You talk of
Anemia.
more important investigations.
Anemia in this case.
Okay.
And
then please continue, Arvind.
Yeah, RFT, and then RFT, and I'll ask for a fasting lipid profile, and then his blood sugar value, RBS, and then FPS and PPS at PA1C, ECG, and then 2D echo, chest X-ray, and the local right foot X-rays.
So, Arvind, the better answer of organizing that answer will be, sir, as the patient is a diabetic hypertensive, yes, I will start by ordering tests to see the control of glucose by a fasting PP and a HbA1c. This is what the examiner wants to hear, along with a hemoglobin, because ischemia can be more with anemia, and in this patient, there is no history of smoking. We'll also like to order for an ECG to see for a cardiac ischemia as well. So this is how you begin the answer. Then, and a lipid profile I forgot in that. Then you say that now I will come to confirming the diagnosis of a critical limb ischemia, something, the new word that I brought you, CLTI, in the limb by ordering a sequence of investigation. Okay, so this is how you start the answer in a postgraduate case. So what is the usual theme of investigations that you start with?
The voice is breaking, sir. Hello?
Yeah, what investigation? Vascular investigation.
What is the
duplex scan?
Mute.
Sir, I will ask for a duplex scan, sir.
Yeah.
Okay. Please continue, doctor.
Yes, sir. I will ask for a duplex scan. followed by an angiography.
See,
And
well,
this case is since, sir.
Sir, stop, please stop. This is exactly the scenario that you are asking for to begin with an ABPI. This is usually the scenario where in an exam, examiners will ask you, how do you plan your investigations? With a handheld Doppler, remember, as sir was saying, this is a very important point, not with your regular stethoscope. This is the point that you can talk about a handheld Doppler for measurement of an ABPI. So once you have done the measurement of an ABPI, then remember, we now proceed to the investigation of a duplex Doppler ultrasound. Okay. Have I made clear? Hello?
Yes, sir, clear, sir.
Yeah.
Okay. Now, if it is an ABPI that you are measuring, important points to ask are, what are the arteries that are seen in ABPI measurement? ABPI,
Anterior tibial.
arterial pressure index.
Yes, sir.
What is the blood pressure in the upper limb that is taken?
Sorry, brachial artery as well as anterior tibial artery will be taken.
Okay, you usually measure it in the dorsalis pedis artery, okay, or anterior tibial artery, whatever
Yes.
it is,
Yes.
right? Now, so what is the normal range of an ABPI?
So it is 1.3, sir. Like more than
More than one.
1.
So, what is the range of normal? You know, again, Arvind, what is the lower cutoff? What is the upper cutoff?
The lower
Yeah.
cutoff is 0.3, sir.
No. Normal ABPI. What is the
Normal. Lower cutoff is 1, sir. Normal.
No, I will
1
take
to
0.9.
It is
0.9.
0.9.
Okay.
And what is the upper cutoff?
1.3, sir.
0.1, 0.4. I go by Bailey and Love, Arvind.
Okay, sir.
0.9 and 1.4 are the cutoff ranges.
Okay,
So
sir.
below 0.9 indicates a hemodynamically significant arterial lesion. 0.9 to 0.4 is the range of the chronic ischemia or stenosis. Less than 0.4 suggests a CLTI. I told you, chronic limb threatening ischemia. The critical limb ischemia, what is out. So please remember, it is not 0.5, 0.4. So up to 0.5 is the range in which there is a stenosis or an ischemia, whatever you call that to be. Okay. Now, is there any other better way of eliciting more objective evidence of an ABPI?
Yes.
If it is 0.9, but
Okay.
still the patient has a claudication pain. I'm not talking of your patient. Your patient always has a gangrene. It is CLTI. Any other way in which the patient has an ischemia, but the ABPI is 0.9, any other way that you can be more objective?
Duplex scan.
No. It is by asking the patient to exercise and then measuring.
Post-exercise ABPI.
It is post-exercise ABPI, where there is a drop in ABPI more than 20%, which indicates now a flow-limiting disease. So please remember this. Next, you get an ABPI. Can you get an ABPI more than 1.4, but still the patient has an ischemia?
Yes, sir. In case of diabetes, sometimes the patient will develop calcification of the.
Very good. Any other disease other than diabetes that can produce more than 1.4 ABPI? Is chronic renal failure. Please remember that. Okay. Now, what is important is diabetics are, remember that, or atherosclerosis is usually going to affect the digital arteries, and that arteries may be totally blocked. Is there any other way to measure something called the ABPI in any other arteries and any other newer developments that you have known which are more objective than ABPI in measuring?
The pulse oximeter.
There is a new concept about something called toe brachial pressure.
Yes, sir.
Okay, so there are digital arteries. Okay,
Yes.
so the toe brachial pressure, remember that is is something less than 0.6. So this is a new concept which has come up. Some examiners will be asking you after you have answered their series of questions on ABPI. Okay, good. So this is all that you should remember about this to remember about ABPI. Now talk about after you have done ABPI, like this patient has an ABPI less than 0.4.
Okay.
What is the next investigation that you are going to do?
Regarding the duplex study, another thing is you find this the sonologist gave a wave pattern of duplex study. How do you interpret this wave pattern?
Absolutely, very good question.
What is the normal wave pattern in a artery? If you place the
Triphasic,
probe
sir.
on the artery, you have a wave pattern being recorded, and you say yes, this is normal. What is a normal pulse wave pattern?
It is a systolic followed by diastolic and the late systolic.
Yes.
Sir.
So it is described as a triphasic.
Triphasic, yes.
If we find the wave pattern is triphasic, we assume that is normal.
Yes.
What happened when the artery get narrowed?
Sir, first the
Stenosis.
late systolic get lost, sir. Usually it will be biphasic or
So it may
monophasic.
become, instead of triphasic, it become biphasic, or become monophasic. Just systolic wave is recorded, the other two waves are not recorded. Okay. So looking at the wave pattern, you can make out the condition of the artery. Okay. So that is another thing you get from duplex study. And previously people used to have a audible signal on the artery also. How do you interpret the audible signals? If you place a Doppler probe over the femoral artery, do you get an audible signal? Normal artery?
Say yes, sir.
What signal you get?
Sir,
you get the same heart sound transmitted to the distal end, lab and dupe. If you place a Doppler probe over the femoral artery or other artery, you can hear the lab dupe sound.
Yes.
What happens in ischemia? You said you ausculted the artery, ausculting stethoscope. Yes. The Doppler probe is a more refined and very sensitive probe. So if you have stenosis, you can pick up the rumbling sound. You can pick up the murmur on a Doppler probe. Okay, these are the few things you gain extra from doing a duplex study. Duplex study is anatomical delineation, any thrombotic occlusion. You can measure the blood flow velocity. You will find that they give a velocity of the flow. In stenosis artery, the velocity increased. Okay. So you should be knowing what are the reports given in a duplex study. Yeah, Dr. Ramanoj, you can continue with the other investigation.
Sir, I think this is exactly the point that you must know about the various waveforms and what is the next, that means what are the points in a Doppler ultrasound. Right. So in this patient, when the Doppler ultrasound has been done, the Doppler ultrasound shows you that there is a monophasic pattern in the superficial femoral artery. Doppler ultrasound says you that there is a length of a stenosis which is around 2 centimeters. Doppler ultrasound also says there is a biphasic pattern into the anterior and the posterior tibial. The arteria dorsalis pedis is monophasic. So this is what the Doppler has told you. The femoral artery appears to be a triphasic. The other limb also is a biphasic in popliteal. So this is all about what we are required to know from the Doppler with the signal. Now what is your plan? So you have performed your diagnosis, everything is done. Now what is the advice that you are going to give to the patient?
Patient has got claudication, patient has rest pain, patient has a toe gangrene. It's not a whole limb gangrene, it's just a toe gangrene confined to one of the tip of the toes. So what's your aim of treatment in this patient?
I'll start with the like I'll make first I'll correct the sugar levels, followed by controlling the hypertension, and then correcting the if there is a presence of hyperlipidemia, correct by giving a statin.
What about ischemia? How is the ischemia part going to address? What's your aim?
Sir, I will be giving drugs like celestosol, pentoxyvaline, aspirin to increase the blood flow?
No. He's admitted. You can't just start aspirin. You might need to do some intervention. So don't start straight to aspirin before you decide about the plan of treatment. Aspirin is and already he has got a critical ischemia.
Okay.
So aspirin is needed, but not at this point of time. If you are planning for some intervention, will you start aspirin straight away?
No, sir. No.
I am talking of any intervention you plan for this patient.
Sir,
The aim of treatment should
I
be
will
relief of pain.
plan
Number
for
one.
a conservative amputation, sir.
No, before amputation. You see, if you do amputation, you have not addressed the ischemia, this will have dieback.
No. See, doctor, what Sir is trying to impress is upon you is that, you see, the Doppler has told you that there is an area in the superficial femoral which is a proved area of a 2 centimeter stenosis. He has told you this one.
Okay.
Now, you have the patient with a gangrene. So, the patient is controlled diabetic, the patient is a controlled hypertensive. Now, what is your plan? You can go in for an amputation, know that. But do you plan to have a revascularization of the limb?
Yes. So aim will be to improve circulation.
Yes.
And to improve circulation with a localized narrowing in the femoral artery, what can be your preferred
I'll go
mode?
with an endovascular technique, sir.
No,
Yes,
doctor, again, endovascular open surgeries are methods of revascularization. But before that, you have to know what is the status of the arteries in the limb. You need an anatomical image of the arteries.
Yes, sir.
So any anatomical imaging of the arteries that you would like to do to know that is this the only artery that is blocked? Are there any collaterals? What is the proximal inflow and what is the proximal outflow? Most importantly, if I need to do a bypass, endovascular, whatever you call that to be, you need a distal target artery. So these are the things that you need to know. What is the investigation? Someone has written something in the box. What is the investigation that you are planning to do in this group of patients?
And I will go for an angio. I'll go
Okay, what kind of an angiograms are planned?
Sir?
What kind of
you
an
have
angiogram?
different modes.
Sir,
You have now had different
I
modes of
will,
getting
I
angiography.
will plan for a MRI angiography, sir. Or like a digital subtraction angiography.
No, so Dr. C, there are three investigations. One is a digital subtraction angiography, one is a CT angiography, one is an MR angiography.
Okay.
When will you do each of them? You don't do all three.
Yes.
You usually will do one of these, and definitely that is the reason for that.
DSA is invasive or non-invasive? DSA is invasive or non-invasive?
So non-invasive, sir.
DSA.
Doctor,
DSA is invasive.
digital subtraction angiogram. What is the thing that is subtracted in the angiogram?
The other structure cells than vascular.
No. What is the thing that is subtracted in that angiogram? In the DSA? Your voice is
DSA is an invasive investigation. You need to cannulate and do the angiography. You subtract the soft tissue shadow. You only have the vascular shadow. So it's invasive. So invasive you will do when you plan to do a intervention.
Absolutely.
Okay. So before that, you have other facilities like Dr. Mukherjee said about MR angio or CT angio. You can have a very good delineation. In MR angio, you may not use a contrast, but in CT angio, you need to use a contrast.
Excellent. So that makes me ask you, what scenario will you use a CT and what scenario will you use an MR? See, the rule is very simple. Sir has already given you the hint.
I'll check for an RFT.
Very good.
So
that means if the kidneys are good, with an EGFR that is good, you can do a CT angio. Kidneys are bad, you can do an MR angio. But what is more important is, remember, if it is suprapopliteal, CT angios are good. If it is infrapopliteal, definitely it is good to think about an MR angio, because CT angios are not great when you see beyond the popliteal arteries. But your disease in your case is something limited above this. So CT angios are readily available. MR angios may not be available due to expertise problems. MR angios, if the kidneys are good, you can use a gadolinium contrast. It also gives a good image, but you need an anatomical mapping. Then you plan for this. What is more important in a CT or an MR angio is you get to see the aorta and the iliac arteries. Maybe there are other stenotic lesions proximal which are not seen by the Doppler. Remember, Doppler could not show you the iliac arteries very well.
Yes, yes.
So this is the reason you always go in for a CT or an MR angio before you think about an invasive like a DSA. So the CT angio in this patient shows you again that there is a 2 centimeter lesion in the superficial femoral. There are few collaterals in the lesion. Now what is your plan?
The endovascular techniques.
Okay, now doctor, tell me now, as we are inching more towards more difficult terrains, how do you determine endovascular or an open bypass?
By task 2 guidelines.
Okay, task is old now, sir. Task is now replaced by more specific entities now. Like there is something called as a glass system. Okay, there is something called Wi-Fi system. So please read about this. But yes, if you are mentioning about task, so what is the task type that will do or make you do an endovascular? What is the task that will make you do a bypass?
So class are like totally there are 4.
Raman, we will conclude in 2 minutes.
Yeah, sir, we'll be ending.
2 more minutes. Around
Right.
9, 8. Yeah.
9, it
Yeah.
is 9. Need to
Yeah.
end out.
Just tell us the indication for a endovascular procedure. The length
Right.
of the stenosis,
The length of
the
the
rectal patency.
Yes, so there are totally 4. A, there will be a single occlusion less than 5 centimeter, and B, there will be multiple occlusion of less than 5 centimeter or single occlusion more than 15 centimeter. In C, it will be multiple occlusion more than 15 centimeter. In D, chronic total occlusion of more than 20 centimeters. Sir.
Okay, good.
And A and B will plan for an endovascular approach, and then C and D will plan for an open bypass.
Very good. So if you are doing an open bypass, what is the arteries that you are planning to bypass?
Femoral disease.
Femoral, common superficial femoral. What is the bypass that you are planning?
Saphenous vein reversible.
So it will be from the common femoral to the popliteal artery or a fempop bypass. Okay. What is the conduit that you are going to use?
What graft you are going to use? Graft.
What is the graft that you are going to use? Will it be a natural graft or a synthetic graft? See, doctor, the important thing is that if you are below the inguinal ligament, it is always preferable to use a vein graft. People nowadays also use arteries as graft, but it is always the best thing below the inguinal ligament is always a vein graft. Which vein is used for a conduit or a graft?
Saphenous vein.
Which saphenous vein?
Great saphenous.
Doctor, time is short. We need to end up within
great
2 to 3 minutes.
Saphenous vein, sir.
Great
Yes,
saphenous. Yes. But great saphenous vein has valves, no?
Yes,
so what will you do to those? Yeah, so you can reverse them or you can destroy the valves. Very good. Okay. So now you have done a femoropopliteal bypass. Good one. Now the patient wants to go home. Your operation is successful. And when will you like to do the amputation? Before the bypass or after the bypass?
So after the bypass, sir.
Why, sir?
Because that will help for healing.
Very good.
Revascularization is done there.
Good concept that you have made. It is after the bypass because, as you have very rightly said, the amputation stump will heal better, and whatever is your line of demarcation is very clear cut after the one. Good one. So this is a new concept. But remember, the patient is a diabetic.
Okay. Right. Raman, we have very good discussion today. Very good. This is what a final MS or DNB exam goes on for a peripheral arterial disease. And
Right.
Arjun, you have presented very well, very good presentation. As second year PGT, I must appreciate you. You have done what should be the ideal presentation for a peripheral arterial disease.
Absolutely.
Okay, thank you very much, Dr. Ramani.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank
Thank you
you.
so much.
Thank you.